The average annual premium for employer-sponsored health insurance for a family is now more than $23,000 per year and climbing. That's just crazy. It's also unsustainable. Many companies have given up hope that anything can be done in healthcare to lower costs and improve value, leaving them feeling like a snowball in, well, you know where. I'm Josh Butler, healthcare consultant and advisor to employer organizations around the country, and this is Season 2 of A Snowball's Chance in Healthcare, a show about restoring hope in healthcare. Our mission is to help employers lower their healthcare and benefits costs, become more competitive and profitable organizations, and put more value back into their employee benefits.
And now, here's your host and 2022 Broker of the Year, Josh Butler.
Hello again, and welcome to another episode of Snowball's Chance in Healthcare. It's a great day in the Texas Panhandle. It's a little bit cold, but hey, you know, we like the wintertime around here. Today, I have a special guest with me, but first let me introduce myself. My name's Josh Butler. I am the president of Butler Benefits and Consulting. We're a healthcare consulting and brokerage firm in Amarillo, Texas. And I'm also the program of this host of this program, A Snowball's Chance in Healthcare. And today I got another good friend and a special guest on with me, Adam Berkowitz. He is the president of Simpara HR, also Simpara Health, located in St. Louis, Missouri. Welcome back to the program, Adam.
Thanks for having me back, Josh.
You bet, man. Is it cold in St. Louis today?
It's freezing cold here, man. And they closed all the schools today. And, you know, now that means the wife has to take care of all the kids. It's a crazy house right now.
Well, I know. And you've got 3 little ones and another one on the way. Congratulations to you guys. I know she's expecting pretty soon here. That'll make number 4 for Mr. Berkowitz.
Yeah, building a basketball team, you know?
Yeah, absolutely. We had a snow day last week. Amarillo got a pretty big snow, and it was pretty nice. And kids got to stay home for a day or so. But yeah, it's cold here today. Single digits this morning.
Bundle up, my man.
I hear you. Well, hey, Adam, thanks again for coming on the program. Just like each and every week, ladies and gentlemen, we're tackling a topic in healthcare to give people education and give them tips and strategies on how to reduce the cost of healthcare, or maybe how to improve the quality of their benefit designs. We talk a lot to employers, and we talk a lot to just employees as well. And today we're going to cover a hot topic that's been out there in the news. Adam, all the Democrats are taking a victory lap. And even though a lot of this work started under the previous administration at the federal level, Democrats are out there touting, we capped insulin prices at $35 for patients. Many of you may have heard that through the Inflation Reduction Act and the Affordable Insulin Now Act, that the feds are going to cap insulin prices for Medicare patients at $35. Initially, Adam, what are your thoughts? You think that's a good thing? You think it's a bad thing? You think it's mixed? What do you think?
That's a loaded question, Josh. This is a complex topic. And you know that's why you wanted to build an episode around this. I think, look, what this fails to address is the cost of the medication in and of itself, right? Capping the members' copay or the cost share, the price they pay at the pharmacy, doesn't change the fact that insulin is expensive in this country. But in and of itself, right, this is going to score good political points. It produces a really good soundbite in the media. There's no doubt about that. But it's also limited to Medicare. 157 million people rely on their employer for health insurance coverage. And then you have Medicaid, which is state-based programs. And so there's a whole lot of the population that's just missing out from this legislation, and that's not included in the sound bites.
Yeah, absolutely. I tend to agree with you that it absolutely scores some political points anytime you can say, we capped insulin prices at $35. No, you didn't cap the price at $35. You just capped what Medicare recipients pay for expensive drugs. And we're going to give some examples of that here in just a minute. But you also brought up another important point, is that, this is only applicable so far to Medicare recipients, people 65 and older, or people that qualified maybe through disability benefits to qualify for Medicare early. But I want to point out it's a pretty important thing, because this is a bipartisan. I think that Congress is trying to find ways, but they always get mixed up between the actual cost of health care and the actual cost of insurance are what people pay out of pocket. But there are two senators, Senators Jean Shaheen, she's a Democrat from New Hampshire, and our favorite Republican Congress lady from Maine, Susan Collins. Those two women are pursuing a bill, Adam, that would actually not just cap insulin at $35 for Medicare patients, but it would cap out-of-pocket cost and co-pays and things like that for privately insured patients at $35. What's your initial reaction? What do you think would shake out if it were to extend over to commercial private plans?
I think that has an uphill battle. So, I mean, I think we need to look at the reality that ever becomes law, but also recognize that, Josh, in your and my industry, we do this all the time. I mean, plan design is such a significant component in making high performance health plans work for our patients that we're serving. I mean, that's the work that we're in. And so, we design copay structure and copay design around adherence all day long. So I don't think there's anything fundamentally wrong with capping the cost to the patient. But to your initial point in question, we're not addressing the cost of these medications. And the cost of these medications has to be paid by somebody. And in the world that you and I operate in, that's the employer. And if we take a step back from that, we're talking about compensation, right? Any dollar paid on behalf of an employee's health plan is in the realm of total compensation. And so we have to address the cost somewhere down the line. Capping the copay, it's important for a few things, but we're missing the bigger picture.
Yeah, and I just want to bring something up because before we get to that, we've talked before on this program about how we have pricing problems in healthcare, not at cost. I mean, the cost to manufacture insulin, I've looked at many researches, data, outcomes from studies and programs that I know you've looked at too. It costs like $10 to manufacture a vial of insulin. But I mean, there are companies out there selling it for $300, $400, $500 a vial. And I think one of the big problems, and weigh in on this, Adam, there's three manufacturers, though, that control 90% of the global insulin market. Imagine that. I mean, a global market, there's diabetics all over around the world, right? And these companies, these manufacturers are selling insulin to people from all over the world, not just Americans. And those three companies are Eli Lilly, they manufacture a Humalog, Novo Nordisk, who manufactures Novolog, and then Sanofi, who's got their whole Lantus lines, like their Lantus Solostar. And we're going to talk about some prices. But don't you think that that's part of the problem, is that we've got three manufacturers that occupy 90% of the global market?
It is a problem, Josh. I mean, but I think what exacerbates this whole thing is that the supply chain of medications in this country specifically, most people can't even comprehend the complexity behind it. As an employer, if you have a self-funded health plan, or if you're buying insurance through a big insurance company, you're not getting your drugs directly through the manufacturer, right? There's layers and layers and layers. And there's been massive consolidation across those layers in the drug channels over the last 5 to 10 years. But there's really big problems going on. And I think a lot of, there's also a lot of misinformation regarding the cost of branded medications over the last 5 years, because it goes back to sound bites, right? It's very easy to score political points or media points, to talk about the cost of medications going up. And while that's certainly true, we're talking about the list price. Who pays the list price, Josh?
Correct.
Not you, not me, not the patient. Even if you have health insurance, there's rebates involved, there's admin credits, there's all kinds of things being passed through from the manufacturer. 340B pharmacies come into play. So when you actually look at the net price of branded medications, it's gone down consecutively for the last 5 years. This is well documented by Adam Fine on Drug Channels Institute. He's probably one of the leading authorities. Yep. I don't agree with him on everything. You and I talk about this, especially when it comes to things like copay assistance and manufacturer's assistance. But the research and the arguments around the net prices of branded medications falling, it needs to become more of a focus point, because this is not necessarily the manufacturer's fault that medications are so high.
That's true. And if you take that argument about the net price, but I'm going to play devil's advocate for 7, because like you said, me and you kind of debate this and we go back and forth. And I read a lot of Adam Fine stuff, and my positions on a lot of different things. But when we look at the net price, that may be true. But when you talk about things like admin cost and rebates, in particular rebates, the argument becomes down to, are rebates, they don't make it back to the patient level. When you see that the average health insurance, a fully insured health plan, the premiums are inflating anywhere from 7 to 12% per annum, then it's not moving the needle. And if they want to make the argument, well, without drug rebates, they'd be inflating at 15 to 20. Well, prove that. I mean, you can't hardly even prove that. So
Right.
I get that the total net price from the manufacturer's position, but are those things like rebates flowing 100% back through and ending up in the pockets of the Americans who are paying for these drugs?
Not in any meaningful sense, Josh. There's been a lot of conversation about point of sale rebates, and I think that that's really tricky
Right.
to engineer, but just logistically. Rebates in general, you're looking 3 to 6 months in arrears to collect a rebate if you're a self-funded employer. If you're Medicare, Medicaid, or fully insured plan, it's the same time frame, right? So rebates are always looking in the rearview mirror. But what we need to, you bring up a really good point about, is the patient benefiting from these programs? And I would argue the answer is no. The plan sponsor is. Ultimately the plan sponsor is profiting from the rebates. There's a really good argument to be made that employers by and large are addicted to rebates, and when you look at formulary design, by and large they're designed to maximize the rebate yield. Well, guess where rebates don't exist, Josh? Generics don't have rebates. How come we're building formularies to address the higher cost branded drugs and the rebate yield versus the lower net cost of just dispensing generics? And a really good example of this, you mentioned Lantus. Lantus came out with a generic 1 or 2 years ago,
Yeah.
but no formulary, virtually no formulary in the country covered it. How come? It
Yeah.
cost 50% less, but nobody was covering it. Why? Because Lantus had a rebate. People
Absolutely.
wanted the rebate. Never
But it's not
mind.
just the plan sponsors, though. I mean, very few. I mean, I know when we look at plan documents and we look at PBM contracts, even for self-funded employers, you very, very rarely ever see a PBM contract out there where the employer or the plan sponsor is getting 100% of their rebates back. So it's not plan sponsors, in my opinion, that's making out like bandits on these rebates. It's PBMs.
Yeah, it's PBMs, but it's also, I think we've been conditioned as purchasers of health plans over the last 2-3 decades, that this is the way that it is, and so we want to see
Yeah.
that larger rebate number. We want to see how that flows through the spreadsheet. We're not looking at reducing our rebate yield and increasing our generic utilization. I mean, that's where it really matters. I mean, we want generic utilization at like 90% or above. The reality is most plans don't hit that metric.
Right.
But doing that would lower healthcare costs dramatically. And
Yeah.
we're
And
talking
today,
about the same high quality healthcare to plan members. And guess what? What's the patient's copay for a generic versus a brand? It's dramatically different.
yeah.
And
And then,
so, yeah.
yeah, and if you look at medical adherence, every $5 you raise a copay, I think the adherence drops like 20%. So, I mean, these are real dollars to real people. And today we're just talking about, the impact here on insulin specifically. I mean, I think you
hmm
and I just kind of went down a rabbit hole there about in general
hmm
about some of the misaligned incentives in the way we procure and the way generic medication and not just name brand insulin is procured and bought and sold, and the
hmm
control over formularies and the manipulations that go on there. But you just mentioned something that very, very important. But the net price, is may have gone down. But when I look at like Atlantis Solostar, that when it came out in 2011, you know what it sold for? Per vial in
No clue.
2011, $34.81.
How about
And I
that?
know that there's a generic equivalent available today, but today, Lantus Solostar is up there around $220 a vial. That's 715% increase in price. And so as we talk about people like self-funded employers, they're paying the price. They are paying the gulf here. And so are people that are on high deductible health plans, Adam. Let's talk a little bit about that, because we've seen this and we've talked a lot about it on A Snowball's Chance in Healthcare, this mass exodus of employers moving into high deductible health plans, especially here in Texas. I mean, it's not uncommon at all to see $3, $4, $5, $6, $7,000 individual deductibles. And talk a little bit about how, insulin prices are affecting people that are on high deductible health plans.
Well, there's two things here in my mind. One, the promise of high deductible health plans. When these started 20 years ago, the promise was, if we push more financial dollars onto the employee and their family members, they'll, as if by magic, overnight, you wake up the next morning, you have a new ID card, and you're a better healthcare consumer, right? I mean, that's how they were sold. That price sensitive shoppers would start shopping for more effective, more cost effective avenues for healthcare. Well, healthcare is not a transparent market, Josh, not in any meaningful sense. It's very hard for a consumer to navigate for price and quality in healthcare.
Sure.
And you made a comment earlier that is spot on. Consumers are highly, highly sensitive to price and when it comes to healthcare. And it's just a $5 or $10 copay change, and now adherence plummets. And you might think, looking at utilization, that's a good thing. Oh, our utilization went down. Well, when we're talking about medications, especially insulin,
we're talking about insulin. We're talking about it's like oxygen for like a diabetic. I mean,
right? You can't have utilization go down. You need to have adherence, at 80% or above. That's what's recommended. And who's tracking that? Are plan sponsors looking at their adherence of these programs, and how their copays are designed and structured? And high deductible health plans don't have copays, Josh. You got to meet deductible first. Most people cannot afford to. And what's happened? So the big promise that moving to these plans will make us better consumers, and as such, the price will go down over time, hasn't happened.
Yeah, and people ask me all the time, well, when we show them some alternatives. International sourcing is an example. I mean, because when you look at things like Humalog and Novolog and Jardiance and all these medications, Ozempic and things like that, these new drugs that have come to market, I gave an example of Lantus Solostar. It's $210 a vial in US, but in Canada, I can get it for $89. So again, we just have pricing failures, and we've talked what are some of the reasons that you see, Adam, why same manufacturer, right? Why are they so much more expensive in America?
Why? Well, these other countries have price controls at the government level, and we're not talking about copay controls. We're talking about price controls. Right. So they're buying in bulk at a federal level. I mean, that's very different. But what's interesting is these countries, they provide really good information and really good data for us to digest, especially when biosimilars are coming to market. And a lot of these insulins are biologics now. You mentioned Ozempic, you mentioned Humalog. And when more competition comes into play, we can look to countries like the UK and Canada to see how that's impacted utilization and drug switching and things like that. So it's going to be very interesting to see over the next few years, kind of the drug landscape in the US as it relates to a lot of these biosimilars coming to market.
I think so too. Yeah. And, you mentioned something like, take Canada, for instance. They have socialized medicine there. And you said, they're one payer, purchasing in bulk on behalf of all the Canadian citizens. But, we have the largest third party payer in North America, which is Medicare. We've got more people on Medicare than Canada's got citizens, so I think that could go a long ways. And I do feel like there's bipartisan support at a federal level to get Medicare in the game. And a lot of people don't know that Medicare hasn't been able to negotiate drug pricing with the manufacturers, which I think is just a colossal mistake. We're not utilizing our buying power at a federal level.
Right.
And then the other thing is just no transparency. I mean, when you just say, hey, look, your copay is only going to be $35, people don't care what the ultimate price tag is, and they don't care who's paying it. Right, Adam?
That's right.
Even if it's their employer, even if it's their self-funded employer, someone is paying that tab. Now, let me transition a little bit, though, that's self-funded. We get that. But even on a fully insured case, you buy, I'm going to pick on them, Blue Cross, Blue Shield, PPO plan, right? And you're fully insured. If this copay cap happens to make its way down to commercial plans, people are going to feel like, well, I'm shielded because we're fully insured and my copay is only going to be $35. What do you think the carriers are going to do, Adam?
Well, you're going to raise the premium. To your point, someone's got to pay it. Somebody has to pay it. And at the end of the day, it's ultimately the employer and the employee. The insurance companies are not out there to lose money. That's not even a comment to vilify the industry. They're not going to price their products when the reimbursement rates, have to support it. So, at the end of the day, somebody has to pay the bill, and that's going to be the working Americans in this country. And understand that taxpayers are the ones funding Medicare. And so all of this is intertwined, and it's a big ball. And you mentioned Medicare not having the ability to directly contract for the price of medications.
Mm-hmm.
But what they've been doing is limiting the cost that patients are paying. We saw the donut hole in Part D started getting squeezed closed. You're
Mm-hmm.
seeing these price caps on insulin. The next phase, I believe, is you're going to see rebates have to outweigh inflationary impacts if drug costs outweigh inflation. And so it's all cosmetic, right? It's all cosmetic, meant to appease people. It's very hard to find politicians on any side of the aisle to argue against stuff like that, because it's too easy to target, right? You say one wrong thing and all of a sudden you're here to kill seniors. I mean, that's just right.
Or if you price fix, then you're a socialist, and now we're a communistic country, and we're going to tell manufacturers what they can charge. How far away do you think we are from that? And do you think that's the only true way to get a hold of pricing in healthcare in this country, is for somebody to step in and say, you can't charge that much money for that?
Josh, don't get me started. First of all, we know that socialism doesn't work, because at the end of the day, you run out of other people's money. It's that simple. It's that simple. You know how many times you can tax somebody who's super wealthy at 100%? Once, right? Because after that, it's gone. So we have to step back and say we need more transparency. Without question, that's number one. We need to introduce more competition in this field, and we need to break down the monopolies that exist. There is so much anti-competitive behavior, and especially if you look at Humira, which is coming off patent. We're seeing all the biosimilars about to hit the market just as soon as, I think, this week. They filed hundreds of patents, and it's just this thicket of complex patent litigation, and they're settling cases even after their patent expired to prevent competition from entering the market. They're buying off their competitors. Why? Well, this drug is hundreds of $1 billion in revenue worldwide.
It is.
They can afford to.
Hundreds of billions of dollars. Yeah,
billions.
I mean, it is. I read an article the other day that Humira is the best-selling drug of all time in human history. And it's a very interesting story, and people that get very, very frustrated, they may not know all the details of AbbVie's history of how to extend patent protections by 10 years. They did it 3 times. And man, it's crazy what we allow in this country. When people like Dave Chase said, we've been to war for less in this country. We went to war over a tax on tea. And then you see what happens in this crazy industry is just insane.
You better believe it. The waste is extraordinary. And as consumers, we pay for all of that. We pay for all of it. It's the largest hidden tax, of our lifetime, probably 2 or 3 lifetimes, that this has been going on.
But guys like you are giving me hope, and you're doing similar things up there in Missouri and getting a lot of results. I want to have you back later in the year for you to share some wins and some case studies. We're kind of wrapping down this episode, but I know that you're building highly customized plans up there for your clients and clients that you work with around the country. Same thing we're doing here with High Plains Health Plan and out in East Tennessee as well. But super proud of you, man. What do you got coming up that you want to tell the audience about?
We're about to launch Simpara Health here in the next couple months, and it's really exciting for us because the vision behind this is that working Americans deserve access to high quality and affordable health care. And we know that we have the wherewithal, the tools, the strategy, the talent on our team to deliver on that promise. And so the synthesis behind Simpara Health is to do as much good as possible with the resources that we've been given. And so
Amen.
we need to scale the adoption of this in our own market, in our own communities, for the benefit of everybody. We're going to have all generic medications on our plan are going to be no copay to members. Brand medications are $25. So we talk about insulin design and copay design is going to be highly affordable under our programs. And we just see nothing but opportunity in the years to come. And, it's on the heels of folks like you, Josh. You're an inspiration to our whole team, and we recognize the work you guys are doing in the Panhandle.
Well, I appreciate it, brother. Well, guys, that's going to do it for this week. This is Adam Berkowitz with Simpara Health. Hey, Adam, thanks so much for joining us today. And join us next week where we're sharing strategies and tips and solutions to give you and your company a snowball's chance in healthcare. Y'all have a good weekend.
Thanks, Josh.